Folks, we're going to go ahead and get started. We're going to have some others that'll be coming in. There were some other meetings going on, and then we were a little late getting out of there. But we apologize again for holding y'all up. But let's go ahead. And first, we're going to hear from Commissioner Fitzgerald, Department of Public Health. Commissioner. Wait a minute.
Sorry. Thank you very much. Is that better? Okay. Thank you very much for this opportunity to speak. The first thing I want to do is our organizational chart, because I think the most important thing that's been done, at least as far as the infrastructure is concerned, is that we set up a new department at your direction, and that was done without additional state funds and without additional federal funds, and we're very pleased with this because we think that provides the opportunity to have closer and more important oversight by the governor and by the legislature, and we thank you for that opportunity. The next slide is our mission, and our job is to prevent disease and promote health and well-being and prepare and respond to disasters. The next slide is a slide that indicates our funding sources. This is important to know because when we look at the 2% cuts that we arranged, we want you to know where those monies come from. If you start at 12 o'clock and go counterclockwise, the first group of monies is the grant and aid to the counties, and as you know, as we explained about with the amended budget, the change to grant and aid is being instituted this year, so we did not want to remove any of the cuts from the grant and aid. Next are federal matching funds. We don't want to reduce any state funds there because we don't want to lose federal funds. The next is public health administration, and that, because of the new department, we didn't want to cut there. The next is labs. I'll talk about that a little bit later. The Georgia Trauma Commission is a pass-through. So the next is the public health programs, which is 11% of our budget, and the entire 2% of the cuts needed to come from that sector. The next slide shows the general trend in financing of public health in Georgia. You can see a significant decrease from 2007 to 2011, and this is the amount of money per person, which includes both state and federal funds. There's been a significant problem this year, which is the next slide, which is the preventative health and health services block grant funding has been decreased by about $1 million. This is problematic for public health because that's our most flexible money. A lot of our federal money comes down with a definite assigned purpose, and we don't have any flexibility with moving it back and forth. And these monies in this grant are more useful to us, but you can see there's been a significant reduction. The next slide is represent our changes. The ones in yellow are increases in the budget, and the rest are decreases. I will walk through, with your permission, starting at the first, 37.1. That's a reduction in funds for personal services. There has been we recommend a reorganization of our teen centers, and that amount of $107,000 represents the restructuring of the teen center design, and I'll get to that a little bit later and tell you that in detail. The next amount of money of $80,000 was unallocated funds that were set aside for pilot projects, and that was part of our cut. The next cut you see is the most significant cut. That's the $3.5 million, and that represents TANF cuts. There were 17 states that had supplemental TANF funding. That was cut precipitously by the federal government, and we do not expect those monies to be returned. So those TANF funds are very significant and problematic. The next is adult essential health services, treatment services. That's $6,000. We were able to substitute tobacco money for those funds, so that those have been backfilled. The increase is the increase in the Macon facility. I'll explain that again in detail later. The next is emergency preparedness. For those funds, that was simply a delayed hire that did not represent giving up any current staff. Epidemiology, the next one, is also a delayed hire. The immunization cuts, 37.6, had no impact on vaccines. We simply cut temporary workers and also some office overhead, and were able to realize those savings. The next one, 37.7, auditory verbal contract, we were able to backfill those with maternal child health federal monies, so that's a simple swap. When you see the $137,000, that's what we took from the state budget and replaced it with federal funds. The next $200,000 decrease to the tertiary centers is a true cut, but we were able to identify some administrative funds, and those cuts were taken from administrative funds only. The 37.7 again is tobacco money was replaced for those personnel services. In the infant and child health promotion, the amount you see of the $2.8 million is the other significant cut from TANF funds, the same sourcing that we discussed before. The $200,000 that you see then on the state funds is cut from Children's First. That was a recommendation that we made before we understood the true significance and impact and amount of the TANF funding cuts that were coming from the federal monies. Those were monies that were coming from the state, and we thought that we could have some efficiencies, and so those cuts were taken there as part of our 2%. The infectious disease control is a delayed hire, and the last one, increased funds for the lab, is an addition. Please look at the next slide, and I want to discuss the problematic cuts, the two large significant cuts. If you'll see the TANF reductions, you can see on your left-hand side the $5.3 million. That is including the amended budget and fiscal year 2013, and on your right, the Children First monies. The next slide will tell you what we propose to do with the TANF reductions in the adolescent health and youth development. We combined them so you could see the true impact. There are basically 30 statewide teen centers, and with these huge cuts, we could no longer afford the teen centers. We want to reduce teen pregnancy, which is the purpose of this program. So what we did is we kept 9 youth coordinators. We are doing a research project in personal responsibility education in the areas that have the highest teen pregnancy rates, and so we kept those coordinators so that we can look for best practices. And that left us with about $400,000, which we are going to award to those teen centers that are actually demonstrating true decreases in teen pregnancy. Our thought is that we don't have the money to backfill this now, but we will look for best practices, so if ever money becomes available, we will know better what to do. The next slide is for the reductions to to Children's First. I need to tell you that Children's First is a program that is designed by the state to identify children at risk very early in their lives. At Public Health, we have all birth certificate information, and that information is collected and returned to us. We've identified areas that indicate children that might be at risk, such as teen pregnancy, a low birth weight child, possibility of complications in the pregnancy. That information is on the birth certificate. That information comes to Public Health, and it happens to be about 25% of all babies in Georgia that are born in Georgia are identified and come to us indicating that there may be some problem. This money then goes to the local health departments, and we do developmental screening, to make sure that the children are developing and that there are no problems because of the complications in the pregnancy. The other Children's First service has to do with referrals from DFACs for children with identified abuse and neglect. That's about 4,000 to 6,000 children per year under age 3. And those children are referred to us, and we are responsible for, again, evaluating those children and see if there are developmental delays. At that point, then the people in the local health departments will connect those children with needed services. We can go possibly put some of them in Babies Can't Wait or some of our programs, or we connect them to local services. The next is the positive money that we discussed about. In the Macon district, we had an extremely old facility housed there. Luckily, it was right next to the hospital, and the hospital wanted it, so we were able to sell that 1946 vintage building for about $900,000. That went into the general funds, and the increases you see are the lease monies to replace that office. The next increase is in our laboratory. Because of, again, going into a new department and establishing closer control over our monies, we were able to redesign our billing services. And what you're looking at, what had been done in the past is that there had been across-the-board cuts that would have resulted in an elimination of our testing syphilis and HIV in our labs. Since testing for communicable diseases is certainly our prime objective, and when our lawyer read the regs about this, he indicated that if we did not do the testing, it was his judgment that we would pay for the testing in an outside lab. So we certainly wanted to replace those funds to do the testing in our lab, and these are the governor's recommendation, the 228 for amended and $421,000 for this year. With the new billing that I discussed, the next, you can see that from April, when we started the new program, to January, which is a 9-month period, we've had a $1.3 million increase in collections over the previous year. If you take the entire amount of money that is for the amended budget and fiscal year 13, and if you remove that from the increased revenues for this past year, that still leaves us with $668,000 that is a positive for the general funds. The accomplishments, I want to say that I am very honored and pleased to be in the new department. I appreciate the opportunity, and I think we have done some very good things. One of the problems that we were facing was that we did not have, we needed some financial improvements. We did not have a centralized location of the grants. That's now been done. We have improved the contracting process. When I got there, the first week I was there, I signed a contract for routine lab supplies that had been in place for 8 months. And that's now down to 10 days. So I think that that shows that if you redesigned the government you have, you can get more efficiency, and I'm very pleased about that. We've been contacting other states to look for best practices in all our programs so that we can more efficiently run our programs and make sure that we deliver services to the people of Georgia in a timely and efficient manner. Our fraud prevention, we are especially happy about our fraud prevention. We have hired a new inspector general who is from the police department, who did police work in Cobb County. He has, and his staff of 20 additional investigators have been doing careful work, and that resulting in identifying those fraudulent vendors in the WIC program. We have now closed, if you looked at the amount of business they were doing with WIC, it represents a $53 million savings for the federal taxpayers, and we're very pleased about that. We are determined that with WIC that we're going to be good business partners with our good business partners, and that means that we want to work well with the reputable dealers in Georgia, but we want to make sure that those dealers that are not reputable are not given that advantage. We've also had restructuring in our HIV program. In the infrastructure, vital records, there was a bond passed because we needed a complete overhaul of the vital record system. That project is on time and on budget. It will result in electronic input, and it will result in the people of Georgia being able to obtain their medical records for $1 less per record, and we're pleased with that. It appears to be going well. The IT system, there needs to be a lot of coordination an improvement of the IT system in public health. We have had an offsite. We've come up with a plan, and we are working that plan, but it will take a while. In WIC, as I said, we want to be good business partners to our good business partners, and we are continue to work with the WIC state plan to make sure that that happens. The new grant and aid formula has been implemented, and the last improvement is we have some significant projects that we are working on, because public health's position should be to prevent disease and protect lives. We have the information to do it, and we can apply that information that we have so that we get focused concentration on problems. So I think that we can improve lives, and also, by the way, the nice side effect is that we also save money for medical care costs for the people of Georgia.
Thank you, Doctor. Do we have some questions from the members? I've got one. Well, let's see. Here's one who is Representative Gardner. Okay, go ahead.
I hate for you not to have any questions, Mr. Chairman. Thank you. I want to thank you for your working on the HIV funding, unscrambling some of the questions from my community, and we will continue to work with you and your budget director, who seems to be able to help us understand the numbers a little bit better.
Excellent.
And we'll continue to work with you. I'm still concerned about the teen centers, and I understand that you're looking for best practices. And is there a focus of those best practices?
We have, in my opinion, we need to do more research into that. And so that's one of the things we're looking at, is for those teen centers who are practicing to identify those best practices. We have not identified those yet. We simply know that looking, for example, at the Athens teen pregnancy program, it's been extremely effective. And its teen pregnancy rate is half that of some of the other teen centers. So what we have not completely identified that now, but that's going to be a matter of study, and we expect that we will make those requests at early spring.
Well, you mentioned personal responsibility, and I guess my antenna went up. I mean, obviously, we need personal responsibility as well as birth control. I mean, it's part of personal responsibility.
Right.
Is that part of the program?
Yes.
Thank you.
Thank you, Mr. Chairman. It's as far as HIV drugs go, is there a mechanism? I know the governor is doing some very innovative things to get our nonviolent senior people out of jail to draw down federal dollars. Is there a way? And I'll tell you the scenario. We've got some of our local jails all over the state, and I've heard from them, where people will leave. They won't take their medication whenever they leave the jail, and somehow will come right back in, recidivism as it is. And, of course, then they become resistant to the HIV drugs, which are extremely expensive.
Right.
Is there a mechanism to coordinate, or is there a federal barrier that allows these HIV programs to serve jail populations that might be?
There's no barrier, sir, that I know of. I certainly will check on that specifically and get back to you. I know that what we need to do, I am certain, is to have a HIV program that makes sure that people continue their drugs. The Savannah program, the Savannah public health program, is an excellent example, and perhaps you know of that one. I mean, they do an excellent job. I mean, they do an excellent job in making sure that if somebody comes, and these aren't jail patients, of course, these are people who are non-incarcerated, but if somebody doesn't come in for their drugs, that somebody goes out and finds them. So they have just an excellent program. What I'm hoping is I want some best practices throughout the state of Georgia. There's certain of our local public health departments that are doing exemplary work. Savannah, the HIV program, in my opinion, is one of those. So what I'm trying to do is to get the people that are doing well in one area to share that information with folks in other areas, so that we can have, excellent services throughout the state in all areas. But the Savannah program is wonderful.
Thank you.
But we can certainly, look into that about working with corrections. We know that the very best prevention for HIV is treatment. I mean, if you have an HIV person that's treated, there's a 95% chance that they will not pass it on. If they are not treated, there's a significant chance that they will pass it on. And we are interested in absolute prevention, so we'll be glad to look into that.
Commissioner, let me ask you to talk just a little bit more, if you would, on this TANF money that we talked about, that you're losing the federal dollars. I think that when you had a discussion, there's a portion of the programs that you are required by law, if DFACS presents a child to you that's been abused or something, don't you have to, you're required to do some investigation on that part, and that's what part of this money was being used for?
Yes, sir, that's true. We are required, it's called CAPTA requirements, and it's the Child Abuse Prevention law, and these are all children that come to us that are under 3 years of age. And last year it was over 4,000 children. And the average number of children that we are required to see because of those concerns it's between 4,000 and 6,000 per year. It's a significant number of children.
Additionally, we have a federal requirement that we screen children for eligibility for the Babies Can't Wait program. And while there's not a large number of children, there's about 4% of the children that are actually eligible for Babies Can't Wait. We are still required by the Federal Department of Education to screen for those as well.
Okay. Representative Gardner, you have another question?
I'm curious about the screening that you do for abused children. The reporting goes to DHS?
Our part of it is for developmental delays.
Oh, for those specific children that are identified in your program.
Exactly.
Not the same children that are being treated over in DHS.
Actually, they can be over in DHS. It's from ages 0 to 3 only. Some of these are, in fact, already foster children. And so we need to screen them to see if they've been injured to the extent that it's causing them to be delayed, or are there neglect issues going on, nutrition, diet, etc., that are causing the children to be delayed, so that we can link the parent with the provider that can best help that child.
What happens when they're 1 day past 3?
And then 1 day past 3, I think they start going over to the DOE side.
Yes. Then the Bright from the Start funding
takes over.
And certainly when we were looking at this, because we were concerned about this loss of TANF things, one of the things we certainly did was talk to Commissioner Cagle to see if there was any expertise or any monies that might be conjoined, and there is not.
But there's you working on transition to make sure they don't get dropped in that.
Yes. Yes.
Commissioner, talk to us just a bit more about the lab work that y'all are doing. I know that when you went in, you redid the procedures, the processes, the billing, and this sort of thing, and you were able to capture a lot of dollars that really we just had not been doing in the past. And one of the things that I'm concerned about, I know that your main lab is here in Atlanta, and you're located near CDC, and of course they do great work out there too.
Yes.
But it's necessary, is it not, that we have a state lab that can do these kind of things too, and we can't depend on CDC to do a lot of that. Would you just talk to us a little bit about that, please?
Absolutely. We in public health are responsible for the medical part of bioterrorism. That means that all the suspicious substances, all the white powders that might come through the mail, come directly to our lab in Decatur. All the air sampling around Atlanta for bioterrorism agents come to our lab in Atlanta, and that needs to be an ongoing protection for the people of Georgia. In addition to that, our lab is a reference lab for the other labs in the state. There are also some things that we do that are not, that certainly the CDC doesn't do, and that has such a high problem, like rabies, for example. We do all the rabies testing, so there's certain studies that aren't done in private labs at all, and certainly aren't part of routine CDC work. So we need to have a main lab, one, because we're responsible for all the evaluation of people who are exposed to any kind of infection and seeing what happens and tracing those contacts. We're responsible for making sure that the state is safe from a bioterrorism point of view. We're responsible for newborn screening. Every single newborn in the state is screened for 28 different things within 3 days of their being born. All of those testing, that kind of testing is not done at the CDC at all. That kind of newborn testing is done in state labs across the country. So there are unique things like newborn screening and rabies that only the state lab does. There are diagnostic things where we serve as a reference lab. There are safety issues, and quite frankly, the CDC couldn't handle those for every single state. We have to, even though we happen to be next door to them, we have to make sure that we keep the people in Georgia safe.
Thank you. Any other questions? Thank you very much.
Thank you.
Let's see. Next, we're going to hear from Craig Young, Executive Director, Brain and Spinal Injury Trust Fund.
I want to thank the chair and committee members for the opportunity to present the Brain and Spinal Injury Trust Fund Commission's 2013 budget request. For fiscal year... Sure. The red light's on? Can you hear me? Okay. I'll get closer. There we go. Okay. For fiscal year 2013, the Commission requests a budget appropriation total of $2,396,580. Please find 37.13.1 and 37.13.2 on page 6 of your tracking sheet. Everybody's found that? Our request reflects a base budget plus $500,000 from our unappropriated reserves, less the reduced collections from the prior year of $37,128. This increase will in part pay for new software and customization for a new web-based database, new website, and equipment so we may better serve our consumers. But the primary purpose is to make additional funds available for grants to Georgians with traumatic brain and spinal cord injuries. I'll be happy to answer any questions the committee may have.
Okay. Any questions? Thank you very much.
Thank you.
Okay. Next, Jim Pettijohn, Executive Director, Georgia Trauma Commission. There. Let me turn it on.
Hello, is this working? Thank you very much. I'm Jim Pettijohn. I am the Executive Director of the Georgia Trauma Commission, and with me is Judy Geiger. She's our Business Operations Officer. On behalf of Dr. Ashley and the other 8 dedicated Commission members, we thank you for this opportunity to speak briefly about our FY 2013 budget. Dr. Ashley would have very much liked to have been here today, but he has trauma call in Macon. The Commission's FY 13 budget has yet to be developed. We anticipate that is to be patterned after the 2012 budget. The Commission meets next month on the 17th to go over that budget. The plans for, we recognize that the Governor's call of recommendation of $15.9 million is tied to super speeder revenues. We had hoped that the revenues over time would have picked up to the original projections of $23 million, but that's not the case. We have been a growing organization. I think at the very beginning, the Commission's statutory authority was to build the trauma system, but I think they wanted to ensure that we strengthened and stabilized the trauma system. You remember in 2006, 2007, when the commission was first formed, the state had just lost DeKalb Hospital as a trauma center, and there were other centers that were threatening to also self-de-designate. Since 2007, I believe the commission has been very successful in strengthening and stabilizing Georgia's trauma system in collaboration with our partners with OEMS, Office of Emergency Medical Systems and Trauma within public health. We have focused on building that state trauma system in a regional concept. We've developed regional trauma advisory councils. We've been very successful in establishing those in EMS Regions 5 and 6, and in 2013 we'll be working with the councils in Regions 9 and in Regions 1. Regions 5 is around the Macon area, Region 6 is Augusta, Region 9 is Savannah, and Region 1 is the northwest section of the state. We've had conversations with EMS Region 3, the Atlanta area, to have them come on board. It's important that you understand the Regional Trauma Advisory Councils are a group of stakeholders, trauma centers, all hospitals, EMS services, public health, and leadership within these communities that come together to do an assessment of the capabilities and capacities that each region has for trauma care. They develop a plan. We have a framework that we have provided to each of these regions that sort of provide the roadmap for a regional plan. There's a pre-hospital, a hospital, an injury prevention, as well as a registry or a data-driven process improvement piece of the program. And each of these regions have one common element, and that is our communications. We have, beginning January 1st, we stood up and are now taking calls 24/7 at our Trauma Communications Center in Forsyth, Georgia. This is very exciting. We are now taking calls from EMS field medics with patients injured into scene, calling the communications center based on our software and the data that we receive from all trauma centers as well as our participating hospitals. We are able to make recommendations on the most appropriate hospital to take that patient. We're also providing that service to smaller community hospitals that for one reason or the other have a trauma system patient that they're not able to take care of, and they need assistance in transporting that patient for definitive care. We just began that in January. Hopefully this time next year when we come back to you, we'll have some very good data. Our goal for the commission is to get the right patient to the right hospital at the right time. We're measuring that by identifying and studying from the time of injury to the time of definitive care, and we're very excited. For the first 3 years, I think the commission was really finding itself and determining what its goal is. I think now this upcoming year and the next 2 or 3 years we'll have metrics to really present to you on the efficacy of our program and how well we're helping the people in Georgia. Thank you.
Okay, we've got a question. Representative Chanel.
You mentioned that the super speeder thing wasn't working out too hot. How much? It was $23 million that was projected. Was raised a few eyebrows around here, but what is it bringing in?
Last year, it's about $14, $15, $16 million. It's interesting. There's two parts to it. The first part, which was the $200 speeding fine, was estimated to bring in around $7 million. And then the second part, the part two, was the suspended license reinstatement fees. That was projected to bring about $17 million. Well, that indeed is it's the other way around. We're finding that people who are getting the speeding tickets are actually paying for their fines, but unfortunately, folks who have suspended license are not reconnecting with the state to get their license back. So we had a very slow run-up. Collections were down. I think they started out 10 or 15% overall, and I think we're now at 15 to 30%. The governor has linked our budget to the projected revenues, and for this year, 2012, it's 15.9, and we were advised to have project our budget in 2013 to 15.9 as well.
Thank you.
Any other questions? Okay. Representative Garner.
The work of the Trauma Commission is new, I guess, to all of us. And then you mentioned that you don't really have a budget for the next year yet. Would you mind providing me with information, kind of source of revenues, how much comes from which of the programs that you mentioned, and expenditures to date, so I can see kind of?
Yes, we can. I can send that to you, and I can briefly talk about it. We have all of our revenues come from the super speeder bill. It's General Assembly funds. The super speeder bill it provides funds to the General Assembly, and that is then provided to us. We don't have the trust.
One-time appropriation?
No, ma'am. Yearly. Yearly.
Yearly appropriation of a certain amount.
Certain amount, and it was projected to be $23 million. And over time, as the governor has and you have wanted to align us more with the actual revenues, that amount of money has decreased. 2012, we were provided initially with $20 million. $2.5 million of that was linked to ARA funds for our potential use. We quickly realized that we were not in the game there, so we subtracted that. There was another $1 million applied to the commission through the budgeting process, and then when the governor made his recommendation for the amended fiscal year 2012 budget, we received a $1.7 million cut, so we're now at 15.9.
Sounds pretty complicated to plan.
Indeed, and we have a very involved commission, and the commission is almost 70 or 80% of the money goes to the stakeholders, trauma centers and physicians, as well as EMS. It's provided to the trauma centers and physicians based on readiness as well as uncompensated care. The commission sponsored a process where we brought all the trauma centers together in a room using the American College of Surgeons Committee on Trauma's standards for designation. We determined the readiness cost for Georgia, a template for all the centers to use. So they're all using the same standards. We have readiness costs identified for a level 1 and level 2. The readiness cost for a level 1 is around $5 million a year. For a level 2, it's $2.5 million a year. The trauma centers 1s and 2s provides over $40 million a year in uncompensated care, and that's just for the severest of injuries. Last year, we provided to the trauma centers and physicians $10 million.
That's helpful. If you wouldn't mind providing me with some more information, I'd appreciate it.
I shall send it for sure, but I also recommend everyone go to our website, and I know you hear that often. It's Georgia
It's
Trauma.
all there?
Yes, it's GeorgiaTraumaCommission.org. We have all of our minutes, all of our budgets, our grant offerings are all posted there.
I'd be glad to do that.
Thank you. And my contact information is there too if you want to send me an email.
Okay. Thank you. Other questions? Okay, Jim. Thank you.
Thank you.
Okay, next we're going to have an update from the Primary Care Summit. Denise Cornegie, there she is.
We can do it without it. I have a copy of the PowerPoint there if that's just as easy for you for time's sake. It's up to you. Thank you, Mr. Chairman, for the opportunity to come back and to update all of you on our Primary Care Summit. I'm Denise Cornegie, the Executive Director of the statewide Area Health Education Centers, and this is Dr. Jim Hotz, who is an internist from Albany, Georgia, who chairs the AHAC primary care work group, and so was the spearhead behind our summit. And I asked him to be here in case there were questions afterwards. I think you all have the handout. The first part of it is a restatement of the GME issue. I think probably you guys have gotten that now, and so you don't need me to reiterate it. But I do want to say that as the summit progressed, the issue of GME was clearly the #1 issue which emerged as a priority for the state. As a summit, we were academically neutral, we're programmatically neutral, the AHECs are neutral. We don't recommend how it should be done, but leave that to the legislators and the policymakers to make those decisions. But I would like you to turn to page 4, and just very briefly, we held our second summit October of 2011. The attendees, we had 98 attendees. We had invited about 190, and it was sort of last minute, so we had a very large turnout. And as you can see, it was a well-representative turnout. We had all 5 medical schools. We had a host of teaching hospitals and community-based teaching hospitals, professional organizations, federal and state agencies. We had a lot of input and a lot of activity, and we spent a day chewing on the issues. And the way that we did this is to say we needed to look at the 4 phases of medical education. First phase being K-12, second phase being undergraduate college, third phase being medical school itself, and fourth phase being GME. And so what you'll see is some of the issues. If you look at the phase 1, this is when the PowerPoint would be helpful, these are numbers looking at our pipeline. And I think that as a summit, as we review this, the pipeline issue, oftentimes people feel like it's fine, that we have enough kids in the pipeline, that that's not an issue. This is current 8th graders in Georgia, and if you follow the progression of the trajectories, it says that by the time these kids graduate, we'll have 8,000 kids in the state who will be seeking a post-baccalaureate degree. That is an optimistic projection based on current trajectories. Now, those are post-baccalaureate degrees in any field. That's not just medicine. And if you look at these data by region in the state, it gets very dismal. For example, I just wrote a grant and looking at these data for the 38 counties in southwest Georgia, that number was less than 700 kids who would be seeking a post-baccalaureate degree. So we feel like there are issues in the pipeline that need addressing, and so we have recommendations responding to those pipeline issues. If you look at the second year in undergraduate, the years of college, we know that the biggest challenge that we were identifying was the quality of college advisement, and we have recommendations about this. But what we know right now is that if you go to the University of Georgia and you're pre-med, you and 500 others, about 30 of you will go to medical school. And the rest of you will find out as a senior that you don't qualify because you've made C's the whole time you've been there. And so instead of redirecting these students into other health professions, they leave and go into business. So the quality of advisement is another issue. When we get to the medical school years, one of the issues is that we don't have defined ways for students to self-select into certain tracks. We don't have those admissions policies. We need to look at these. We need to explore these. Other states have done these successfully. We don't need to recreate wheels. We just need to look at what's out there. So we have recommendations about that. Of particular note is the number of 3rd and 4th year community-based training sites. Years ago, a couple of years ago, you guys invested heavily in medical school expansion. Well, now those expansion students are hitting the pipeline needing to go out into community-based settings. While at the same time, we cut the funding to support clinical training. So at the time when we have the most medical students ever needing community-based assistance, we have the least resources for it. And that's a huge problem, and that's exacerbated by the fact offshore medical schools and out-of-state medical schools are now paying sites in Georgia. So Florida State University considers South Georgia as its playground, and they are paying preceptors down there to take medical students. Well, Georgia programs do not pay. So we're having increased competition for these sites because the offshore schools pay a lot of money, and Florida State pays significant money for sites we pay nothing to. And so one of the recommendations is to look at some sort of provider, primary care preceptor tax credit to acknowledge these community-based providers who take Georgia medical students as opposed to out-of-state or offshore without making direct payments to them. If you look on through, we have laid out for you sort of a timeline of when different things can happen. We have also taken the liberty of looking at what could be funded legislatively and what perhaps we ought to seek outside funding for. So as you look through the last part of it, you'll see the specific recommendations and what we think needs to happen and how we need to move this forward. And again, I speak on behalf of the whole summit. The AHEC is not the recipient of these dollars except for the community-based training dollars to help with the student expansions. But this is a bigger picture than just us. And we think that there needs to be a serious long-term group looking at this holistically across all 4 phases and creating balance in the system.
Okay. Any questions? Please tell us a little bit about these out-of-state schools and offshore schools that are paying clinicians to bring the students in.
Sure.
How much do they typically pay?
It's all over the map. A lot of the offshore medical schools their students have to do their 3rd-year rotations back in the U.S. And those students are responsible for finding the sites. I have heard reports that they are paying up to $1,700 for a month. Some people say more. Jim, you may know differently. $1,750 to $2,000 for a month of training. Now keep in mind that each medical student in the 3rd year needs 6 or 7 rotations that last 4 to 6 weeks. And so if you do the math on that, it quickly becomes cost prohibitive. We can't afford to pay that as a state, I don't think, especially with 5 medical schools. But the offshores can. There also are no limitations on how many students they can take. And there was an issue, I know, in Rome, Georgia, where a physician was taking between 7 and 12 students at a time from an offshore school. Well, there's no quality there. Florida State University practices under more stringent guidelines, but they're taking sites all over South Georgia. And, frankly, if you get an offer from someone who's going to pay you $750 for a month versus someone who's going to give you a smile and a certificate, you'd probably take the $750.
Yeah, I think so. Well, I think that, I want to thank you for putting this information together, and I want to thank the governor for his attention in his budget. I think we've been talking about this for quite some time now, and it's finally gotten to the level that everybody realizes that something needs to be done. Now the question is how best to make that happen with the resources that we have. But I think that's something that we all want to get into, and I think it's proved beyond a doubt that if you take a Georgia student that attends a Georgia school that does a residency in Georgia, chances of that student staying and practicing in Georgia is very good, as opposed to if they go out of state to do their residency program. You may get them back or you may not.
Right. And you'll notice that these recommendations, some of them are short-term time limited, just to take advantage of low-hanging fruit until you can actually get the system in balance as you want it. So for students who are currently seniors in medical school or starting seniors, getting ready for a match, if we can create incentives for them to match in Georgia and stay in Georgia, that may not be something you want to adopt long-term, but as a short-term measure to fill our slots and to fill them with Georgia grads, it may be something to consider. And then as the system moves forward, you could remove that. But we got to get some low-hanging fruit, because how long is it going to take us to get residents if we start tomorrow? 5 years? 5 years. Yeah. And we need some before then.
Need them, don't we? That's right. Okay, any other questions or comments from the group?
Our next summit will be in May, in probably Macon, and you all will be invited, and I hope you'll try to
Good.
attend.
We'd like to hear from you on that. Thank you.
Thank you.
Okay, that concludes our agenda of the departments and all, and next we're going to have a portion of public comment, and we had a sign-up sheet, and we've had several folks who have signed up. So first we'd like to hear from Greg Harry. And Mr. Harry, if you can you come up and we'll turn a mic right there for you, and yeah, let's try that one right there. I believe that's 12, isn't it? That's on, isn't it, right? That mic's on, isn't it? Yeah.
Is that close enough? Okay. Always figure out a way to improvise here. My name is Greg Harry. I'm 48 years old, and I just wanted to come and talk to you about the Independent Care Waiver Program. I was 20 years, a little over 20 years ago. I was had an accident that left me paralyzed from the shoulders down. I was 27 years old, and since the age of 14, I've been working for my next door neighbor's small business. He had just started in his house, and I got to sit there and watch the company grow and grow with it. And I was traveling and we were doing lots of hands-on stuff within the business. And then when my accident happened, it kind of prevented me from pursuing that any further. So I had to make a change in the way I live my life. And the Independent Care Waiver Program allowed me to stay living in my house and get the kind of help that I would need to stay living at home instead of being institutionalized. And I was on a waiting list for 3 years before I was able to get on the program. And then I got on the program, and it gave me assistance every day to help me live my life. And we've got 130 people on a waiting list, that same waiting list I was on for 3 years, that are trying to get community-based health care help to stay out of an institution. And I just want to come forward to say that it does make a difference in my life to be a part of my community and to not be institutionalized. And it's been a 20-year adventure, and it's had some good points and it's had some low points, but I've been very blessed, and I just want you to know that this program could help those other people.
Great. Thank you. Any questions or comments? Thank you. We appreciate you taking the time and the effort to be here with us today.
I thank the committee. Have a good day.
Okay. Next, we're going to hear from Dr. Michelle Zena, who is a pediatrician down in the Bullitt County area, who happens to be my constituent. So y'all be really nice to her.
Thank you. I am a pediatrician in private practice in a rural area, and I see lots and lots of children on Medicaid, and a few children on Peach Care, and a few children with private insurance, and a handful of kids with no payer at all, for various reasons that have slipped through the cracks. And most of my children that have no payer at all have eligibility. They should be eligible for Medicaid or Peach Care, but there have been logistical problems. And I just have to say, as somebody who spends almost about 60 hours a week taking care of children in our community, that the difference that it has made as a small business owner for the 0.5% cut to be rescinded and for us to know that things are going to stay stable where they are is huge. It makes such a difference. And the about 18% of my patients fall into the private insurance group, and about 15% of my patients have Peach Care. And to know that in the coming year, the Peach Care kids' reimbursement is going to be on par with Medicare. And I hear my colleagues who take care of adults talk about how terrible Medicare reimburses, and I just think, oh, I wish I could get that. It would make a huge difference if I got paid those amounts. We could hire a nurse to do care coordination for our non-compliant patients, and all kinds of things that we could do. the impact that little bit, that 1 year is going to have is going to be huge on the children in our community. And, you know, as a small business owner, it's going to be a big impact on me. I'm probably going to be able to hire somebody. You know, not a full-time person, but it's going to make a difference. And, you know, the following year, if all of President Obama's plan is followed, then everything else is going to be on par with that amount. And we're going to have a lot more rules that we have to follow. So I'm sure I'm going to need some staff to implement all of that. You know, overall, it makes a really big difference. And, you know, we haven't gotten a raise in Medicaid reimbursement rates since before I was in practice. In fact, I think since I was in medical school. So, which was like 13 years ago, I think was the last time something changed. And, you know, it makes a big difference. I'll be happy to answer any questions about the small business aspect of things. I can also express my appreciation that y'all did round things to even numbers. You know, we've never had change to make change in the office, and to have to start doing that would be a real big hassle. The 41 cents and the 63 cents kind of stuff that we were not real excited about the logistical challenges there. And I'm sure that some of our patients are not going to have their Peach Care copays, and we'll have to absorb that cost because it costs more than $3 to bill somebody. And if your child is sick and they're in the office, we're not going to tell you that we won't see you, which is part of how I end up with the no pay patients that I see already. But the increase in reimbursement for Peach Care on par with Medicare just helps take away that sting, and certainly makes it a lot more tolerable.
Thank you. We got a question from Representative Gardner.
I appreciate the need for a reimbursement rate that will allow you to continue to live, but I was curious what you mentioned something about the logistical problems. Describe some of the logistical problems of the children who should be eligible for Medicaid but are not.
Well, right now, when a baby is born, if they have right from the start Medicaid, which almost all of my patients do, over 95% of my patients that are newborns have right from the start Medicaid, then they get Medicaid until the end of the month of their first birthday. And the parent gets something mailed to the last address that Medicaid was aware of, which is not necessarily their current address, that says that they need to reapply. And it is often overlooked by parents who don't really have the education to understand what that is or what needs to be done. And so the child is dropped off the Medicaid rolls, and then they have to reapply from the beginning. And so usually they are 13 and a half months old before they have Medicaid again. And then Medicaid reimbursement, Medicaid eligibility is determined every 6 months. And so if you work at a job that you make $7 an hour or $8 an hour, and you have to miss a whole day of work every 6 months to go reapply for Medicaid, and your job is always when Department of Children and Families office is open, which would be 9 to 5, then it's really hard for those families. I also have several families that don't get a pay stub, and if you don't get a pay stub, then
And what's a pay stub?
That little thing that comes on the side of your check that's proof of how much you got paid.
Mm-hmm.
If you get paid,
a pay stub. Sorry.
Yes, sorry. You get direct deposit probably. But patients, families who get, their every 2 weeks paycheck, the people who get paid in cash because they work construction, have no document or anything else like that, can't prove what their income is. And they cannot currently even use last year's tax form, last year's 1040 tax return as documentation, or their W-2 of what they earned. And so they're in limbo. They can't prove that they're poor enough for Medicaid, but they are.
Sounds like you'd be in favor of expanding to 12 months the
Yeah.
coverage.
And I think it would really end up saving money too, because those children between 12 months and 13 and a half months, if they get sick, they go to the ER. And let me tell you, a visit in my office when you're really sick is a whole lot cheaper than the ER. Our most expensive office visits are cheaper than the ER's least expensive visits. And, you know, we have the medical home and care coordination and all those things that make it more efficient too.
I'm sure you've mentioned that to your representative.
Maybe once or twice.
I'm on speed dial. Michelle, thank you very much for taking the time to come up. I thought it'd be interesting to hear from her because she's out there dealing with it in real time, real life every day, and it's interesting to hear some of the challenges that she faces, and we thank you for taking care of our youngest citizens.
Thank you.
Okay, next, someone from the Morehouse School of Medicine, Valerie Montgomery Rice. Is that right? Right here, fine, yeah. Thank you. And if you would just, as you all come up, we've got several more on the list. If you'll just identify yourself and what organization or group you're with, and then we'll try to hold everything to about 5 minutes or so. Thank you.
Thank you. Good afternoon. I am Dr. Valerie Montgomery Rice, the Dean and Executive Vice President at Morehouse School of Medicine. First, let me begin by thanking you for your support provided to Morehouse School of Medicine in the past and your recent recommendation to restore the 2% cut for Morehouse and Mercer's operating grant. It is much appreciated. As a result of your actions in the past and currently, we have been able to accelerate our efforts at Morehouse School of Medicine to increase the MD program and continue our commitment to ensuring that we continue to educate and train providers that are committed to staying and practicing in the state of Georgia. As a Georgia native from Macon, I understand firsthand the need to attract and retain students who want to practice in the communities that need them most. I was one of those persons who received care from a primary care doctor who trained in Georgia and was positively influenced to go to Georgia Tech. And although I went away to Boston for medical school, I came back to Emory to train in OBGYN. As a resident training at Grady, I experienced firsthand as Morehouse School of Medicine transitioned from a 2-year program to a 4-year medical school, establishing its own clinical programs, and eventually with funding from the state operating grant and participation in the federal match, its residency training program, the last of which was established in 1997. Today, we have the 3rd largest residency training program in the state with 155 trainees. 69% of those trainees remain in Georgia to practice medicine and, as you know, primarily practice primary care. I come before you today not just to thank you for your foresight shown early in our school's history to develop a funding mechanism which allowed for Morehouse School of Medicine to educate and train physicians who were dedicated to the primary needs of the underserved, but to seek your continued support for what has been a very successful private and public collaboration. As a freestanding medical school which doesn't own its own hospital, we rely heavily on this private-public partnership with the state. The partnership, which includes our receipt from the state operating grant and the ability to leverage that support to receive a federal match. Those funds are what allows us to establish and maintain our residency training programs through the support of our clinical faculty and administrative support of those programs, and continues to serve as the foundation which supports the clinical focus of our undergraduate medical education program. And it is also the funding that has laid the foundation for us to meet our goal of expanding our class size from its current level of 56 entering students per year to 100 over the next 5 years. The proposed reduction of the $1.4 million would actually result for us in a $4.6 million overall loss in revenue to us. A reduction of this magnitude for a fiscal year which takes place less than 6 months from now would severely impact our residency training programs, with reductions in both resident trainees and faculty who provide supervision to those residents and who educate our medical students in the clinical setting. Equally important, this will decrease our ability to grow our class size as planned. I am confident that you recognize the value that Morehouse School of Medicine brings to the state by increasing the number of trainees who remain in the state and adds to the diversity of the healthcare workforce. Over the last 5 years, 71% of our graduates have graduated in a primary care area compared to a national average of only 40%. And again, 69% of our resident graduates have remained in the state and are practicing in some of the most disproportionately underserved areas. We also know that if you are a Georgia resident and you either go to school at Morehouse Medical School or you train at Morehouse School of Medicine residency training programs, there's a 98% chance that you're going to stay here and practice in the state of Georgia. We are encouraged by the conversations we are currently having with the Governor's Office of Planning and Budget to create a solution that will continue to provide support to Morehouse School of Medicine while we develop a transition plan that will allow us to plan for the foreseeable reduction in federal matching funds and develop expanded alternative funding opportunities, as we have done with the Veterans Administration Hospital. We've developed new private partnerships. We've also identified new clinical affiliations with federally qualified health clinics, but it takes time for those to develop and blossom to make up for the loss that we will see in the reduction in federal matching. The development of these alternative funding sources, along with a well thought out plan for stabilization of our state operating grant and a plan to transition from our reliance on the federal match as it decreases, will allow for us to maintain our strategic momentum to increase our class size and capitalize on the Governor's commitment to expand residency training positions by providing well-educated, committed Georgians who, as we have consistently shown, will fulfill our commitment to the state to educate and train providers who remain in Georgia, producing great benefit to the state and its citizens. Thank you very much, and I will take any questions if you have any.
Thank you, Doctor. Any questions? Yes, ma'am. Representative Gardner.
The governor announced in his State of the State that there were 400 new residency programs. Will Morehouse students be eligible for any of those residency programs?
Yes, we will be eligible. We have requested, both myself as the Dean of Morehouse School of Medicine and the Dean at Mercer, Dr. Bynum, we've requested to be a part of the committee that is looking at how resources will be allocated to support those residency training programs. We hope that we will be allowed to participate because everyone, all of the medical schools will have students who will want to be considered to participate in those residency training programs.
So they have told you that you would be eligible?
Well, the residency training programs will be by the hospitals, be primarily run by the hospitals, and students can apply. So students should be eligible. I cannot think of a reason why a student would not be eligible if they are graduating from LCME accredited medical school.
Thank you, Mr. Chairman. To Dr. Rice, I just wanted to clarify what you said, that this $1.4 million reduction will result in, did you say 4.6?
Yes, ma'am, because the 1.4 is our state operating grant, and then we're able to leverage that with the federal match, and it's around about 4.6, which it ends up totaling. So we won't be able to run that through our hospital partners to leverage that to get the CMS match.
Okay.
Any others? Okay. Thank you very much, Doctor.
Thank
Thanks
you very
for coming.
much. I appreciate you.
Okay, next on our sign-up list, Sheila Ryan.
Good afternoon. I am Sheila Ryan. I am the state director with the March of Dimes here in Georgia, and I wanted to come today and speak on support of restoring the funding for the Children's First program administered by the Department of Public Health. Children's First has been funded through the supplemental TANF grant from the federal government. As you know, late last year, federal support was discontinued for the supplemental TANF funds to Georgia and 17 other states, resulting in a $2 million reduction to Children's First in fiscal year 2012. The amended budget and a $2.8 million reduction in the fiscal year 2013 budget. The Children's First program provides a single point of entry for families into a wide range of public health and community programs. This statewide program identifies and screens children from birth to age 5 that are at risk for poor health and developmental outcomes, refers and links them to appropriate services, and monitors their health status. There are Children's First coordinators in Georgia's 18 public health districts, and 15 of the 18 coordinators are nurses. Other staff essential to the program include universal newborn screening, hearing screening coordinators, additional nurses who are not coordinators, developmental specialists, dietitians, and professional health care workers. Children's First is available in all county health departments at no cost to families to access these services. In fiscal year 2011, Children's First identified 46,905 newborns and children as needing medical and or developmental services. Funding reductions of proposed magnitude contained in the fiscal year 2012A and 2013 budgets will make it impossible for Children's First to continue to operate as a statewide program. Without Children's First, approximately 8,500 low birth weight and very low birth weight newborns will not receive nurse home visits services, and approximately 30,000 newborn and children with potential medical and developmental concerns will not be linked to the appropriate medical and developmental services that can improve their health outcomes. The March of Dimes is really dedicated to improving the health of infants and children and making sure that moms are healthy throughout their pregnancy. We are working to prevent premature birth and infant mortality. Georgia's Children's First program provides a systematic way for children and newborns in Georgia, and this approximately is about 150,000 births per year, so it's a big number, to be identified for conditions that would otherwise result in poor health and poor development. We strongly recommend Georgia legislators to restore funding for Children's First so that the program can continue to operate statewide and can identify all newborns and children needing medical and or developmental services during these early years that are most critical to the healthy child development. So thank you very much for your consideration.
Thank you. Any comments or questions from the group? Thank you for being here with us. We appreciate you coming. John Howell, Georgia Healthcare Association.
Thank you, Mr. Chair, distinguished members of the committee. I'm John Howell, President and CEO of the Georgia Healthcare Association. We represent 340 nursing homes, a growing number of assisted living communities, and the home and community-based case management agencies called SOURCE. I've learned through my experience that I can't go through the PowerPoints that I just gave you in 5 minutes, so I won't attempt to do that. What I will do is direct your attention to the ask, and then hopefully we can get to maybe some question and answer. We are very thankful that the governor has put in the FY13 budget a recommendation to update the nursing home cost report from the 2006 cost report that we're currently on to the 2009 cost report. What we'd like for you to consider today is an update to the 2010 cost report. We do have the audited numbers for that year's cost, and the providers are willing to do the bulk of the financial lift in terms of up in the ante on our nursing home provider fee, moving that provider fee from what is currently $13.39 per patient day to $17.10 per patient day, an increase of $3.71. That difference of what we're currently collecting in a self-imposed fee or tax, in Georgia we say fee, but the concept has been called provider tax in other states, but that differential of $3.71 generates over $38 million to the providers through the federal match. What we ask your consideration of, the difference between what we can generate through our own provider fee and what we need to get to a 2010 cost report is $4 million investment by the state. And we sincerely would ask for you to make that financial priority for Georgia's elderly, disabled, and infirm populations being served in nursing homes. Additionally, I have listed there for you a $1.5 million update to for our fair rental property system. This is what's called an RS Means Construction Index. It's another index that's recognized on the national level to account for changes in construction cost. Basically, the fair rental value system incentivizes providers to reinvest in their buildings. We've certainly probably been in some nursing homes across the state that look like they could use a renovation. This property component, as I said, allows providers to be properly reimbursed for those renovations and replacements, and so we ask for your consideration there. And the last thing is very important to our source providers. Service options using resources in a community environment. These case managers keep people out of nursing homes, and they're doing a very good job of it. They're serving over 19,000 people across the state now. And one of the things we've seen in the nursing home world is through the use of these quality incentive programs, we can raise the bar in terms of the quality of the product we're delivering. And now Georgia's nursing homes are above the national average on many key indicators. We want to put that same program in place for the source providers for a small investment of $100,000, a total investment request of $5.6 million. The rest of the PowerPoint really speaks to the need and why we think we're a good value for the Georgia taxpayers. So, Mr. Chair, I probably still went over my 5 minutes, but I'll be happy to entertain any questions.
I thought sure you'd want to tell us that Georgia was at the bottom of the list on the average Medicaid rate. You meant to tell us that, didn't you?
I am embarrassed of that, and I know y'all are not proud of it either. But we are $61 a day away from what Florida's doing. We certainly want to see Georgia improve with regard to their reimbursement rates.
Thank you, John. Any questions or comments for John? Thanks for coming. Okay, Healthy Mothers, Healthy Babies, Linda Lowe and Mary Frances. Is this together or two different things or what here? Okay, well, I've got it on my list. I can't tell.
Mary Frances Williams, Healthy Mothers, Healthy Babies. Thank you so much for this opportunity, and thank you for all the work that you guys do on this budget. It's a tough budget, and I know there's not enough resources to go around. I was going to talk to you about children first. You've heard from Dr. Fitzgerald about that already, and of course the March of Dimes. I just want to say it's not the governor's fault that we've lost the supplemental TANF funds. It's not the department's fault. But one of the points that Dr. Fitzgerald did make is that, right now we are serving many more Georgians with a lot less money than we were a few years ago, and so we just need more resources in the Department of Public Health. I think we're all really pleased with the direction of the department, and I think everything else has already been said. I just want to say again that our public health infrastructure for young children would cease to exist without Children First. So I hope that you will do what you can to find some dollars. I know 2012 is already out of your jurisdiction, but I know you'll be discussing it with the Senate, and any money you can find for 2012 and certainly some for 2013, we really need it because we need to keep these people in place. We need to keep this infrastructure in place. We need to screen these children and get them to the, children with problems. The earlier they're identified, the more progress you can make and the longer you can go to make sure that children don't have problems later on as they grow up. So thank you so much.
Thank you. Linda Lowe.
Speak for two groups because my other person is not able to be here and testify today. I'll be quick. Thank you very much. Really appreciate the opportunity to speak first today about families' first interest in this budget. And by the way, I am talking about the 2013 budget despite what it says in the heading on here. I apologize for that. Families First is a leading nonprofit family service agency in the state of Georgia. I think you all know that. Families First does not directly provide health services, so none of this is about our organization, but we do have to advocate for healthcare access for the families that we serve. It's a very big issue. So there are actually three things I would like to mention today. One is that we're really pleased that you're on a plan to eliminate that 0.5% cut in provider reimbursement. We were very glad to see that. We're also really looking forward to those increases, at least in the primary care reimbursements that are due under the Affordable Care Act. We think that will help a lot, as the doctor said, to bring some of the reimbursements at least up to the Medicare levels. We also have applauded you and the Department of Community Health for some of the administrative changes that they are making to try to streamline the Medicaid and Peach Care eligibility process, and particularly to stop that bouncing back and forth between Medicaid and Peach Care applications. But we do think that it's really important to go ahead and change to 12 months of continuous eligibility. Your constituent, Mr. Chairman, did a great job of talking about why that's necessary, both for the children who lose access to health care periodically just for paperwork reasons, and also for the providers. And we agree with her that the cost of care increases when the kids lose their coverage. Alabama, Mississippi, North Carolina, and South Carolina have already done this with great results, and we just think it's good government efficiency and that it improves the health of children. And then finally, we want to support replacing that funding for Children First that other people have already talked about. We know that we're asking to do more here, although Georgia is just coming out of a rough fiscal crisis. But we think it's really time to match that belt tightening that's been done over the years with doing something about the revenue situation. We really need to revise the tax code and come up with something that's going to allow us to have sufficient revenues to be proactive about getting our state out of the bottom ranks when it comes to children's health and health in general, and other measures that affect our quality of life, so that we can be the state that we want to be down the road. Now I'd just like to speak for just a moment on behalf of Georgia Breast Cancer Coalition, and it's sort of like a sermon. We have 3 points as well, but they're slightly different. Georgia Breast Cancer Coalition is a grassroots advocacy and education organization that was formed and is supported by breast cancer survivors. We are very concerned about the grant and aid funding for county health departments. We want to thank you for last year at least not going along with additional cuts in the county grant and aid, and this year in the 2012 amended budget coming up with some money to try to hold the counties harmless as they switch to a different formula. But we want to ask you to go farther than that. Over the past number of years, the county health departments have taken a huge hit. They operate the Breast Test and More screening program, through which women with breast and cervical cancer are identified and then referred into the Medicaid program, the special Women's Health Medicaid program that covers them for the treatment of their breast or cervical cancer. And what we know now is that because of all the health department cuts, we are way understaffed in the health departments from where we were in 2002. We're down roughly 400 nurses from where we were then, despite the fact that the population has grown. So there are waits. You know, sometimes women can't even get in to get screened, or they can't get the mammograms afterwards. So we'd love for you to be able to do something about that. And also, we too are concerned about provider fees. Once again, glad for getting rid of the 0.5% that was proposed, but need to work on this. And some of these fees won't necessarily be addressed by the Affordable Care Act. So it's something that, you know, we really need the state of Georgia to start scaling them up to match Medicare. And then finally, we're also concerned about the state's ability to make these kinds of strategic investments, and actually hope that you will look at doing what Representative Stevens has worked so hard on, adopting a PAC, a dollar increase in the tax on the pack of cigarettes, and look for other ways to be able to support the kinds of investments we need. Thank you.
Thank you, Lynn. Dave Ziles.
Thank you, Mr. Chairman, committee members. My name is Dave Zillis. I'm a resident of Sandy Springs, and I'm here today as a parent advocate for Unlock the Waiting List campaign, and also as a parent of a 33-year-old son who has a disease called Friedreich's ataxia, which is a muscular disease that he's had since he was 11 and has been on the independent care waiver since 2009. I'm also here representing the 130 individuals that are currently on the waiting list for the independent care waiver. Unlock has focused its advocacy efforts primarily for people with physical and developmental disabilities, and the goal of this campaign continues to be to eliminate or reduce the waiting lists in Georgia for all home and community-based services that support people with disabilities. I want to thank you for your support that you've given us in the past for these very important waivers that literally allow individuals with physical disabilities or traumatic brain injuries to remain in their homes instead of being placed in the nursing homes. I'd also like to thank DCH for currently continuing its efforts on home and community-based services, and currently in 2011 the percentage of home and community-based services now 42%, whereas in 2009 it was 39%, so we're moving in the right direction. I'm also very pleased with what they've done about the recent addition of the application for a program called a Balancing Incentive Payment Program, which is a federal program that's designed to increase that percentage of home community-based services to 50% by 2015, and it's done by an additional 2% match, federal match. So if that application is approved without any additional state dollars, the state would potentially receive an additional about $19 million that can be used for home and community-based services. Now, these services are actually divided between 3 different divisions to cover the waivers. One is DBHDD for the Comp Now waivers, DHS for CCSP, and then DCH for Source and ICWP. It's our understanding that in that division it looks like there might be about $6.8 million available for DCH out of that $19 million. So this is a real positive. I think it's great that the department has stepped forward to try and do this, and we support it in every way we can. My son is like many of the others on the waiting list. He needs help with his daily activities of living, bathing, dressing, toileting, preparing food, and transferring. He is classified as requiring nursing home level of care, which means he could have been in a nursing home, but we prefer to keep him home with us. He receives about 8 hours of personal care each day. Unfortunately, he is unable to work because of his disease, but he enjoys living in the community and likes to go places when he can, and did receive a college degree in psychology. Unfortunately, with a degree in psychology, you've got to go a lot further to do anything with that. John is like many individuals on the waiting list. He was being taken care of by his parents, who are both in their 60s and possibly not able to take care of him because of either their own physical issues or had time to leave their full-time jobs to support him. So one of the things that we worry about in this environment is the parents that are taking care of these individuals may have to leave the workforce in order to take care of that person. I stand here today asking you for consideration for funding the necessary dollars to cover the existing 130 waivers that are on the existing waiting list, and the cost of that is about $2.1 million. So again, I go back, if that balance incentive program does come through and there are $6.8 million available to DCH, I would hope that maybe we could allocate some of that towards the waiting list. These waivers mean everything to individuals, you heard from Greg earlier, and their families. It allows them to live independently and enjoy life as we all do. Thank you for your time and respectfully ask for your consideration.
Dave, thank you very much. Thanks for being with us. Dr. Duncan.
Hello, I'm Dr. Titus Duncan. I'm a general surgeon by trade, and I'm coming here on behalf of the Obesity Action Coalition, representing obesity in adults and obesity in children. And started as I'm a general surgeon by trade, and went on to become a plastic surgeon, primarily because I thought I was interested in making money. But and then I went on to become a bariatric surgeon, a weight loss surgeon. And what we're interested in is primarily the state benefit plan that you know that's been cut. State benefit plan allowed obese state employees to actually have this surgery that got rid of a lot of the disease processes. I went from plastic surgery primarily to bariatric surgery because plastic surgery, in one aspect, got rid of a lot of physical problems and got the obesity corrected a little bit on the outside, but on the inside, those patients were still having problems associated with diabetes, hypertension, sleep apnea, high cholesterol, and things of that nature. And this has been an epidemic, and so I changed from general surgery to plastic surgery. Then I had to go back to something that I was actually trained to do, and that was take care of patients. And in taking care of patients, I had to get rid of the hypertension. I had to get rid of that diabetes, the sleep apnea, and liposuction just didn't do that. And so when I did the liposuction and those patients still died of problems associated with diabetes, I didn't feel very good. So anyway, I've been involved with bariatric surgery, bariatric medicine, actually, for over the past 10 years. And the impact that I've seen, even in the state employees, the impact, we started that program in 2009, where all state employees were covered. And we have a very, very large practice. And so what I've seen after that practice is that we've cured type 2 diabetes. Now, I want to explain that because that's something that's very, very personal to me, because I have a lot of patients in my practice. We all know that the impact of diabetes over the country associated with obesity. But personally to me, I've had two uncles below the age of 50 that have died of complications of diabetes. And diabetes is not a good disease. Diabetes starts with patients who are actually having problems associated with seeing, with kidney failure. Then they start having amputations from peripheral vascular disease, and eventually they have a heart attack or a stroke, and then they die. So that impacted me quite a bit, and I'm pretty sure it's impacted quite a bit of people across the world. And what we found out, and what I'm going to tell you is pretty much going to be amazing to you, because I go across the country teaching this, and that is diabetes is no longer, to me, a medical disease process, because every patient that I've seen has gone through medicine after medicine after medicine. Then they eventually wind up on insulin, and then they eventually wind up with all the complications. You don't ever cure diabetes with medicines. But what we found out with the science of what we've been doing over the past 5 to 6 years is that we're able to take patients and do certain types of surgeries and cure their type 2 diabetes. In our particular practice, we've cured type 2 diabetes in over 6,000 patients 95% of the time. Okay? So that's extremely important. So if you add up the number of dollars that we save by decreasing patients 80% of the time, decreasing their hypertension, 75% of the time decreasing their sleep apnea, 90% of the time decreasing their diabetes. That's a tremendous savings. And unfortunately, the lay public thinks that because they take a pill on their hemoglobin A1C is okay, is normal, they think that their diabetes is under control. Their blood sugar is under control. The diabetes is still affecting them, and we now know in science that, again, those patients still have a shortened lifespan. We don't have to have a shortened lifespan. And so we've been able to demonstrate in our data, and we keep pretty good data across not only my practice but across the country, in that we have pretty good data that show that we have actually impacted those patients not only in their healthy lives, their diabetes, their sleep apnea, their high cholesterol, their heart disease, their stroke levels. We've also improved their quality of lives. In other words, there are patients that come to me that hug me. I used to be on Channel 5 in Good Day Atlanta, and basically they call all the time on Channel 5 and they basically say, Dr. Duncan saved my life because now, he saved my life because now I can tie my shoes. And they think that was saving their lives. So again, they're talking about their quality of life, things they couldn't do before that they're now able to do. One lady came to me, decided that she wanted to have this surgery primarily because she was sitting in the park and she was playing with her kid. Her kid was 2 years old and he was just beginning to walk. And he got up and she was weighing around about 375 pounds. And he got up and he ran out in the street. And for the time it took her to get up and go and rescue her kid out of the street, that kid could have been dead. Now, she actually got up and actually went after him, and luckily there were no cars coming, so he didn't die. But she realized then that she was not there to protect her family. And that's what it's all about. And these people protecting their family. Now, most of the public, and it's been a big challenge to us as bariatric surgeons, as bariatric physicians, to convince the public that all that people have got to do is to push away from the table. And what we actually have now is data to show that there's a bariatric gene, there's an obesity gene. There are other things that are going on inside the intestinal tract. The majority of people in this room probably don't know that certain food elicits a certain hormonal response that either make you lose weight or gain weight. And what happens is that there are patients that come to me every single day say, Doc, I'm going to eat a salad every single day, but I'm still gaining weight. I used to not believe them when I was a plastic surgeon. I used to not believe them at all. But when I got into the science of what I'm doing right now, I believe them. Because I know that 70 to 75% of those patients have an obesity gene, and they, no matter what they eat, they are not going to lose that weight. And it's because everything that they eat, they're going to store as fat. So it's not a myth. It's not just pushing away from the table. It's a disease process that they really have no control. We across the country, across the world, think that they're just lazy. They're dumb. They're just not going to push away from the table. And it is our mission to change that mindset across the world, because now we have science. And some of this science is just as recently as 3 to 4 years ago. We know that now we think that eating salmon is a great thing. But actually salmon, medically speaking, can actually block leptin. Leptin blocks this satiety center in your brain, and it actually helps you gain a little bit of weight. Now, how many of y'all knew that? Well, again, my point is that there are a lot of things that we're gaining because of science that shows that obesity is no longer that thing that we always thought it was, just pulling away from the table and going to get on the treadmill. It is not. It is not. And so what we implore, we're really asking and begging, is that give people a chance, because type 2 diabetes takes a lot of people, takes a lot of resources, takes a lot of money. And over the years, and we know that that the state benefit plan, these patients stay with the state for practically all their employment lives. And so we know that we can save millions of dollars. In the 3 years that we were able to exercise our plan with the state benefit plan, in our practice alone, like I say, we were able to cure, and those patients who had type 2 diabetes 90% of the time. And I'll be glad to show you the data to show you that. So those patients are off insulin, they're off metformin, they're off all their medicines that over a period of years and years and years would cost them. So our bottom line is that after about 2.5 to 3 years, we break even. The state breaks even as far as their cost. And then after that, it's icing on top of the cake. You begin to add money to your budget because you no longer have to pay for the diabetes medicines. You no longer have to pay for them to admit it for the stroke or in the stroke unit. You no longer have to pay for them in the intensive care unit. You no longer have to pay for their cholesterol medicines. This means quite a bit to me, primarily because the oath that I took as a physician is that I will cure as much evil as I can of the body. I thought that at one point in time that I worked hard enough and I was smart enough that I just wanted to make money by liposuction, but now I realize that my calling is basically to make sure that people enjoy the longevity of their lives, the quality of their lives, and that we live to be able to see and to help our children to help our children become less obese. We have a national epidemic now that 2/3 of this country are overweight or obese. 2/3. And that epidemic is rising. So the costs are going to increase substantially. So I ask you and implore you that if you would help us out and reconsider the state benefit plan, we would appreciate it quite a bit.
Doctor, thank you for coming and be with you. I think some of us probably want to talk to you about this fat gene. I think a few of us got a problem with that. But seriously, thank you for coming and taking the time to give us some good information. And we have a question over here.
Yes, sir.
Thank you, Doctor. Yesterday we heard from the commissioner about this, and I'm just becoming educated on the topic myself. And I guess I don't know if you have the expertise to really answer this question, but you're a doctor, and in your opinion, do you think that 3 years that we've been doing this program, or that State Health Benefit has been covering this procedure, do you think 3 years is a long enough time for us to really have enough data to show if it's doing what it's intended to do, and that it's ultimately to improve lives, but also to hopefully save the system some money?
I think what we've been able to find, and this is anecdotal from our series, I think what we've been able to find is that in our particular series, that 3 years is when we start breaking even. When we start, and it depends on it depends upon the severity of the disease process that a particular individual has. If a particular individual comes to our office with diabetes, hypertension, sleep apnea, and high cholesterol, and everything else under the book, it may take a few more years. But just to be honest with you and be straightforward, at 3 years, we're going to think that we're going to probably start to break even, because in the process of even curing type 2 diabetes, we can actually get those patients off their medicines usually within the first couple of months after their surgery. So then, and the diabetic meds, the newer diabetic meds that are coming out there are more and more and more expensive. You're starting to pay, $40, $50, $60, up to $100 per pill. And when you get to that particular point in time, we begin to lose money. So I think that a break-even point is around about 3 years. And as we gather the data, if we want to get really, really strong data, I really think about 4 to 5 years will give us that strong data that really shows, because we've been able to show it in other studies that we have across the country, that diabetes, that curing these particular problems by taking care of this problem with obesity really, really has a long-term financial impact.
Thank you.
Thank you. Thank you very much.
Polly McKinney.
Hi, I'm Polly McKinney. I'm with Voices for Georgia's Children, and we are a children's advocacy organization. And I won't spend a lot of time because you've heard everything that I have to say already. I just want to echo comments regarding the Children's First funding. That's a huge issue for us the 12-month eligibility, and we really appreciate the deciding not to cut the reimbursement rates. A big piece of what we do is child health policy, and all of those things are of key importance. So that's pretty much all I had to say this afternoon.
Thank you.
Thanks.
Appreciate you taking the time to come and be with us.
Sure. Thank you for letting me speak.
Scott Maxwell.
Thank you, Mr. Chairman, members of the committee. I'm Scott Maxwell, and I'm representing the Georgia Public Health Association. And I'd first like to say thank you on behalf of the association for your very perceptive insight and foresight in putting money in the 12 amended for what we call the whole harmless money, grant and aid money for those counties who are ill affected by the new formula for distribution of grant and aid money to local public health departments. And simply would ask you to repeat that wise decision again in the 13. And if you'll allow me to pull a Linda Lowe, there's been so much discussed today about the need for residency slots. We also represent Memorial Health down in Savannah. They have 97 slots where they get federal funding for, but they do another 26 residents that they fund themselves with help from the Physician Workforce Board. But a lot of it is their own money they're put into it. And I know you've wrestled with this problem. I know you appreciate the problem. And I'd just like to second what you've heard today about the need this state has for as many residency slots as we can manage to fund and keep those doctors here in the state. Thank you very much.
Thank you, Scott. Pat Noby? Newby? I think she may have left. Okay, that is the end of the names that I have on the list that I have here. Is there anyone that was here that meant to sign the list that wanted to say a word or two? If not, we thank you all for taking the time to come. We thank you for your interest, and for those who came and testified with us, we appreciate you all being here and taking the time to come share this information. We're adjourned. Thank you.